We are live.
Good afternoon. My name is Dr. Ann Carpenter, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Center for Control and Prevention. On behalf of the One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on September 1st, 2021. Next slide. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in state, federal, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Next slide. Today's presentations will address one or more of the following 5 objectives. Describe 2 key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topics. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. And identify 2 new resources from CDC partners. Next slide. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial products, or commercial supporters, as well as the use of any unlabeled products or products under investigational use, with the exception of Dr. Christina Nelson, who will be discussing some antibiotics recommended for treatment and prophylaxis of plague that are not FDA approved for this indication, for example, gentamicin. CDC, our planners, presenters, and their spouses and partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there is no bias. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this activity. Next slide. Instructions for receiving continuing education are available at cdc.gov/onehealth/ZOHU/continuing education. The course access code is OneHealth 2021. To receive free CE for today's webcast, complete the evaluation at cdc.gov/tceonline by October 11th, 2021. A captioned video of today's webinar will be posted at cdc.gov/onehealth/ZOHU/2021/september.html within 30 days. To receive free CE for the web-on-demand video of today's webinar, please complete the evaluation at cdc.gov/tceonline by October 12th, 2023. Next slide. Before we begin today's presentations, Dr. Colin Basler, Deputy Director of the One Health Office, will share some news and updates.
Thanks, Anne. Hello, everyone. Thank you for joining us on today's ZOHU call. We appreciate you being here today. Before our presentations, I'd like to share a few One Health COVID updates and highlights from today's ZOHU call email newsletter. If you are not yet subscribed, please use the link at the top of the main ZOHU call webpage so you can stay informed. CDC's response to the COVID-19 pandemic continues to evolve. Please check CDC's website for the latest guidance and resources, including information about keeping people as well as pets and other animals safe and healthy. We also hold a regular One Health Partners COVID-19 webinar where we provide news, key updates, guidance, and resources for public health officials, animal health officials, veterinarians, industry and academic partners, pet owners, and others. Our next webinar will take place on Tuesday, September 21st at 2 p.m. Please email onehealth@cdc.gov to receive updates information on how to join the webinar. Next slide. There is no evidence that animals are playing a significant role in spreading COVID-19 to people, but we continue to see animals reported with SARS-CoV-2. In the United States, 222 animals from 29 states have been reported, including cats, dogs, large cats in zoos and sanctuaries, otters, gorillas, and mink. 17 mink farms have been affected by SARS-CoV-2. The latest animal case numbers are available on the USDA APHIS website. Guidance for pet owners, mink farmers, veterinarians, and many others are available on CDC's website. Next slide. Some recent publications of interest include multi-state outbreak of Burkholderia cepacia infections associated with contaminated ultrasound gel, and a notes from the field, delays in identification and treatment of a case of septicemic plague in Navajo County, Arizona, 2020. In today's first presentation, you'll hear about antimicrobial treatment and prophylaxis of plague. Next slide, please. And another new publication to note is Rebuilding for Resilience, how Puerto Rico's Environmental Health Department managed several public health emergencies and emerged stronger. Next slide. Some new announcements of interest include confirmation of COVID-19 in white-tailed deer in Ohio, and a new health advisory network message about the rapid increase in ivermectin prescriptions and reports of severe illness associated with the use of products containing ivermectin to prevent or treat COVID-19. FDA Center for Veterinary Medicine has also posted a notice and a printable poster which provide information for veterinarians and retailers of animal health products on how they can help stop the misuse of animal ivermectin in humans. Web resources to note include tick-borne disease continuing education courses and reopening outdoor public spaces after flooding. Next slide. Some upcoming observances include National Preparedness Month in September, African Swine Fever Action Week, which is September 13th through 17th, and World Rabies Day, which is on September 20th. Next slide, please. And finally, there is a new salmonella outbreak linked to Italian-style meats. Please visit CDC Healthy Pets, Healthy People website for a selected list of ongoing and past US outbreaks of zoonotic diseases. Our next call will take place on October 6th. Please email topic suggestions for future presentations and news from your organizations to zohucall@cdc.gov. We appreciate your help in spreading the word about the ZOHU call by sharing the website link with your colleagues from human, animal, plant, environment, and other relevant health sectors, and letting them know about the live webinars as well as the free CE and video recordings of past webinars. Now I'll turn the call back over to Anne.
Thank you. Next slide. You may submit questions at any time using Zoom's Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation if time permits. You may also email questions for today's presenters. We've included their email addresses on this slide, on the ZOHU call webpage for today's webinar, and in today's email newsletter. Next slide. Our first presentation, Antimicrobial Treatment and Prophylaxis of Plague, Recommendations for Naturally Acquired Infections and Bioterrorism Response, is by Dr. Christina A. Nelson. Please begin when you're ready.
Thank you. Hello. Thanks everyone for listening in, and thank you so much to the ZOHU call organizers for having me. Today, I will be discussing new clinical guidelines for treatment and prophylaxis of plague. Next slide, please. During this presentation, I will review some background on plague and how plague relates to One Health, bioterrorism concerns with plague, important updates to the clinical guidelines, and then finally, I will share some helpful resources and talk about future directions. Next slide, please. Plague is caused by the gram-negative bacterium Yersinia pestis. It survives in enzootic cycles of rodents and their fleas, so basically a low-level smoldering. It can affect prairie dogs, squirrels, black-footed ferrets. Rodents and other small mammals are really most susceptible to plague, but it can also affect mountain lions, for example. You can see the picture on this slide here in the bottom right is a mountain lion that died of plague in Grand Canyon National Park. Plague can also affect domestic pets, such as cats and dogs. Cats in particular are highly susceptible to plague. They commonly present with submandibular lymphadenitis and fever, and owners often seek veterinary care for their cat at this point. Dogs can also become ill with plague. And plague can cause periodic epizootics that leads to large die-offs in animals. So basically, plague explodes in an animal population, and plague can effectively wipe out an entire colony of prairie dogs. Next slide, please. As for human illness, humans can be infected by a variety of routes. The most common route is via flea bite. So a flea feeds off of an infected animal, then bites a human and transmits the bacteria to the human. Handling infected tissues or ingestion of infected tissues can also be a route of infection. For example, a hunter touches an infected carcass and has a cut on his finger where the bacteria can enter. And also inhalation, droplets from a sick animal or human. If a human inhales those droplets, then they can become ill and develop most likely pneumonic plague. It's been shown that a dog sleeping in its owner's bed is a risk factor for plague. So basically the fleas come in close proximity with the human and can jump on the human and bite them. And plague is an occupational risk for veterinary staff, biologists, and healthcare providers. For veterinary staff, for example, if there's a sick cat or dog and the staff didn't know at the time that the animal had plague and examined the animal and then later found out they had plague, there's a risk that they became infected during that contact. For example, several years ago, 2 veterinary clinic employees in Colorado actually contracted plague from a sick dog. And for biologists, the picture actually that I showed you on the previous slide of a mountain lion who died of plague, a wildlife biologist who conducted the necropsy on that animal tragically contracted plague from that interaction and from that contact and died. And also it's a risk for healthcare providers who see patients with pneumonic plague. And the clinical form of plague is tied to the route of infection. So bubonic plague, you can see in the picture here, it's typically caused by a flea bite or direct inoculation and leads to painful swollen lymph node and fevers. Pneumonic plague is caused by inhalation of the bacteria. And septicemic plague is when there's fever and signs of sepsis, but actually no localization. So that one is a little bit unclear. But as I mentioned, the clinical form is tied to the way the bacteria has entered into the body. Next slide, please. Plague is still endemic in many parts of the world. In recent years, most cases have been from Madagascar and the Democratic Republic of the Congo, but plague is also endemic in Asia and the Americas, including the Western United States. Naturally occurring cases happen every year in the Western United States, including, as you can see here, a recent tragic death of a child this past summer in Colorado. Next slide, please. In addition to naturally occurring disease, Yersinia pestis is a potential bioweapon. It's categorized as a tier 1 select agent, which is the highest risk category. And the reasons for this include the fact that it can be disseminated by aerosol, basically as a powder form and released into the air. A person-to-person transmission can occur. If a human has the pneumonic form, they can cough up bacteria and infect other people. So if Yersinia pestis were to be released intentionally, the infection could be propagated further after that release. And there's a high fatality rate for plague if it's left untreated. WHO has estimated that 50 kilograms of Yersinia pestis released over a city of 5 million people would cause about 150,000 infections and 80 to 100,000 hospitalizations and 36,000 deaths. So CDC and ASPR and others participate in emergency response planning related to plague. The good news is that plague is treatable with antibiotics. So there are antibiotic stockpiles around the country that can be used and are kind of maintained for this purpose. The Laboratory Response Network can test for Yersinia pestis and other pathogens. CDC and others do close tracking of human and animal plague cases. Human plague is a nationally notifiable disease, so we collect information from health departments and track these cases. And CDC and other agencies participate in preparedness exercises. And September is actually Preparedness Month, so it's good to be thinking about these things, especially right now. Next slide, please. So on to the specific topic of this webinar. Previous guidelines for treatment and prophylaxis of plague were published in the year 2000, and that was from a non-US government working group. But since that time, new data has become available, and this includes additional human clinical data on plague and animal study data. 3 fluoroquinolones have received an FDA indication for treatment and prophylaxis of plague. And additional safety data on a variety of antimicrobials has come to light. So information on adverse effects of various antibiotics that really should be considered when making these decisions. You can see a screenshot of the previous guidelines here. So in addition to the guidelines being 20 years old, it was clear in light of this new information that it was time to update the guidelines. Next slide. So the 21st Century Cures Act actually mandates that the government must have updated evidence-based guidelines for bioterrorism agents. And we wanted to make sure this entire process of developing the guidelines and updating them was quality in, quality out. So we wanted to gather the most comprehensive evidence on which to base our decisions. So we conducted several systematic literature reviews, and through this captured 922 published cases of plague, including information on treatment and outcomes. And that included 160 pregnant women. So we were able to take a close look at this special population. This information was published in addition to some other information in a special supplement of clinical infectious diseases. And it's available open access through this link you can see here. We also analyzed and published US plague surveillance data. So as I mentioned, plague is nationally notifiable. And so thanks to the health departments that provide information on cases of plague, we have data on treatment, antibiotic treatment and outcomes of various patients with plague. So that was also summarized and analyzed and published in this supplement. Next slide, please. After gathering and summarizing this evidence, we held a forum to discuss treatment options and collect individual input from experts in a variety of fields. And these guidelines, once they were ready, they were actually published this past July in MMWR. And that, again, is open access and freely available. So if you'd like more details, feel free to take a look at that. Next slide. So just reviewing some important updates that are in these guidelines. These updated guidelines included guidance for naturally occurring plague. Previously, the guidelines were for bioterrorism response only, but the recommendations were basically extrapolated to naturally occurring disease. We also added recommendations for additional clinical forms of plague. Previously, the guidelines covered only pneumonic plague, but we added specific recommendations for bubonic and other forms. Added recommendations for specific populations. So previously the guidelines did cover pregnant women, but we also added recommendations for neonates and breastfeeding infants, geriatric populations, and immunocompromised patients. And we substantially expanded the options for both treatment and prophylaxis. So ciprofloxacin, levofloxacin, and moxifloxacin are now first-line agents. Previously, Cipro was listed as an alternative, but it's been promoted to a first-line agent, and previously Levo and Moxi were not included in the guidelines at all. We also added new same-class alternatives to first-line antimicrobials. So for example, gentamicin is a first-line aminoglycoside, and alternatives to gentamicin are listed, including amikacin and tobramycin. And trimethoprim sulfamethoxazole, also known as Bactrim, is a new alternative drug for both treatment and prophylaxis. So these expanded options really help, especially in the case of a mass event from intentional release of Yersinia pestis. We want to have as many options as possible to get antibiotics on board for people who are sick and exposed. Next slide. So these are just the changes laid out in table format. This is for treatment of pneumonic or septicemic plague in adults. So you can see the first 3 circles here, the Cipro, Levo, and moxifloxacin are first line. Previously, gentamicin and streptomycin were the only first-line options for treatment of plague. The only difference for children is, for these first-line agents, is moxifloxacin is actually an alternative since there's much less data on its use in children. And then moving down, you can see these alternatives. As I mentioned, we have a number of same class alternatives, which helps expand options. And then you can see Bactrim at the bottom there, trimethoprim, sulfamethoxazole. There is a separate table for bubonic plague and plague meningitis. These are similar, but there are some slight differences. For example, for bubonic plague, doxycycline is actually considered a first-line treatment. Next slide. And post-exposure prophylaxis is very important, both for naturally occurring disease and bioterrorism response. It should be considered for persons who had close contact with an ill human patient or animal without wearing appropriate PPE. So again, for example, plague is not suspected for an ill cat or an ill human who comes in. They have pneumonic symptoms and expose the veterinarians or healthcare providers, and they didn't know at the time that the patient had plague, but then they were exposed through that route. So this is important for healthcare providers, as I mentioned, veterinarians, other clinic staff, personal contacts of ill patients, family members, for example, and laboratory workers accidentally exposed, persons exposed through intentional release of Yersinia pestis. Prophylaxis can be used for all of these folks, and we recommend a 7-day duration. And you can see in the table here, lots of good options: Cipro, Levo, moxifloxacin, and doxycycline, and there are many alternatives that you can see listed here. So again, lots of good options that are readily available, and this again is very important. Every year, CDC and state and local health departments get inquiries about prophylaxis, often from veterinary staff. So it's good for those who work with animals in endemic areas to have this information on hand and readily available, so you are aware of the options. Next slide, please. And then just some additional resources. The CDC website has lots of information on plague. You can find information on ecology and symptoms and prevention and other things. Surveillance data that you can take a look at, and also fact sheets in English and Spanish. We do have a fact sheet on person-to-person transmission of plague that answers some common questions that people may have related to this phenomenon. And then tables for clinicians and others on treatment and prophylaxis. So these have been boiled down, you can see on the right here, boiled down from the guidelines that were recently published, and can be useful. Health departments and veterinary offices can have this on hand if cases come up and people need to consider prophylaxis. Next slide. And lastly, for future directions, we'll continue to track new cases of plague and publications that include patients treated for plague, and update the guidelines again when indicated. And we are working on some additional plague research projects, for example, a systematic review of patients with plague meningitis. This is a very serious complication, and there's not much consolidated information on treatment, so this will be helpful to pull this information together. And we are also starting to develop updated guidelines on treatment and prophylaxis of tularemia. Francisella tularensis is also a tier 1 bioterrorism agent, so we need updated guidelines on that as well. Next slide. And I'd really like to thank the people listed on this slide. It really took a village to bring these guidelines to fruition, and lots of people worked really hard on this effort. So everyone on this slide, including the entire clinical guidelines team, special shout out to Helen Talley McRae, who is part of the ZOHU call and was part of the communications team related to this effort. And again, everyone else listed here. Thank you again for your attention.
Thank you, Dr. Nelson. Next slide, please. Our next presentation, Stronger Together, One Health Coordination During the COVID-19 Pandemic, is by Captain Casey Barton-Barabush. Please begin when you're ready.
Thank you, and greetings, everyone. It's a pleasure to be here on the ZOHU call today to highlight, on behalf of all involved One Health partners, how we used One Health coordination during the COVID-19 pandemic next. So to start off, a One Health approach to an emerging zoonotic disease like COVID-19 is critical to best protect health. We're stronger together, as no single person, agency, or sector alone can address shared health threats that affect people, animals, plants, and our shared environment. We must collaborate to achieve the best health outcomes for all. Next slide. So to give a little bit of history, and for the reasons I just said, CDC, Department of Interior, or DOI, and the U.S. Department of Agriculture, or USDA, partnered back in December of 2017 to coordinate a One Health Zoonotic Disease Prioritization, or OHZDP workshop for the United States. We did this in collaboration with many other agencies representing multiple departments, and this workshop had two goals. First, to strengthen One Health collaboration at the federal level in the United States by developing shared priorities around zoonotic diseases of greatest concern across all the relevant sectors. And second, developing plans and recommendations to strengthen One Health to address these priority zoonoses. There's a detailed report available, and we presented on this in more detail on a past ZOHU call several years ago. Next slide. But to briefly highlight results, we prioritized 8 zoonotic diseases for One Health collaboration. We had a mix of endemic as well as emerging zoonoses. And please note number 5, emerging coronaviruses. At the time, it was SARS and MERS as 2 of the original coronaviruses of concern between people and animals. But this was on our list back in December of 2017, and that really highlights the power of One Health discussions. Next slide. So as part of this workshop, we proposed action plans and recommendations, and I want to highlight 2 of those because it helped to set the foundation for our federal response to COVID-19. First was creating a formalized One Health coordination mechanism at the federal level, and second was developing a national One Health framework for the United States. Of course, there are some other needs listed here that are also relevant to the pandemic. Next slide. And in the US, we've seen recent congressional support for federal One Health coordination through an Appropriations Committee report toward 2 of the items recommended in that United States OHZDP process. First, the committee directs CDC to develop a national One Health framework to combat the threat of zoonotic diseases and advance emergency preparedness. And second, they direct CDC to work with USDA and Department of Interior to develop a One Health coordination mechanism or structure at the federal level. So this will help us strengthen One Health collaboration to more effectively address zoonotic diseases as well as related One Health work across the federal government. And we're excited to be working with our federal interagency partners to fill these gaps. So now that I gave you a little bit of history and a little bit of what's coming in the future here, I want to tell you how we applied our vision from the OHZDP workshop for the federal One Health response to COVID-19. Next slide. When the virus that causes COVID-19 first emerged, partners across US agencies started talking, asking questions, and raising needs. We quickly realized that we all had similar questions and quite a lot to coordinate. So to help fill this gap, CDC created the One Health Federal Interagency COVID-19 Coordination Group, or OFIC, back in February of 2020, with the goal of bringing together representatives from key federal agencies representing multiple departments. So we had a platform to collaborate and communicate to address the One Health technical aspects of the pandemic. We started with around 6 agencies and now have 22 participating agencies with just over 150 federal partners engaged in these efforts. Next slide. And this slide just shows you the range of agencies engaged from multiple departments across the US government. Sorry, there you go. So just to show you who's involved with this effort. Next slide, please. So to help advance the technical work, we created 5 OFIC subgroups consisting of experts from the relevant agencies and departments to help us focus on the connection of the health of people, animals, and the environment. And we addressed companion animals, animal diagnostics and testing, wildlife and zoo animals, production animals, and environmental health. The subgroups are listed here along with their agency chairs and any relevant subcommittees. So for example, with companion animals, we had subcommittees on mass care and sheltering during a secondary disaster within a pandemic, and one on working animals as well to address those important needs. Next slide. The OFIC subgroups were extremely productive. Here are just a few of many examples of joint guidance that we collaboratively developed on a wide range of One Health issues. things relevant to wildlife, to farmed mink, to companion animals, disaster sheltering, and even on the SARS-CoV-2 case definition for animals. Next slide. So as I said, a foundation of One Health is strong coordination and communication across all relevant sectors. So when we quickly recognize this need to coordinate the One Health aspects of COVID-19 across a variety of partners, you heard about the interagency partners, but we also recognize the need to coordinate with state, tribal, local, and territorial public health, animal health, and wildlife partners, and with other partners such as non-governmental organizations, academic partners, industry partners, and many others. So we created 2 different groups here to coordinate along with the OFIC. We held a weekly coordination call for state, tribal, local, and territorial partners from public health, agriculture, and wildlife, and OFIC members. And currently we're doing this call on a monthly basis. We also hold a regular One Health Partners COVID-19 update webinar where we give timely updates and allow partners to ask questions. So our next call for this is going to be on September 21st. And as you heard earlier in the news, you can email onehealth@cdc.gov to get on the distribution list for that information. So these coordination efforts were really critical to the timely exchange of information, collaborative projects, and best protecting health. And we learned some valuable lessons here that will be applied to creating the U.S. One Health coordination mechanism that we mentioned earlier. Next slide, please. So this figure shows the One Health partners and flow of information and applying One Health coordination to zoonotic SARS-CoV-2 transmission events between people and animals in the United States. And using this highly coordinated One Health approach to SARS-CoV-2 surveillance has allowed us to simultaneously determine both the public health risks of zoonotic transmission as well as the animal health outcomes. And this has allowed us to react to new and emerging situations in real time and adapt our guidance as we learned new information to best protect the health of people and animals. And we've also learned some valuable lessons to help strengthen surveillance and information sharing needs around zoonotic diseases and emerging threats that can be applied to the future. Next slide, please. So because genetic variants of SARS-CoV-2 have been emerging and circulating around the world in both people and animals, it's important to monitor viral mutations and variants through sequence-based surveillance, laboratory studies, and epidemiological investigations. So a SARS-CoV-2 interagency group was established, and one component of that is a One Health Genomics Working Group that's co-chaired by CDC and USDA, and it includes many of our OFIC members. And the purpose of this is to bring together our interagency partners to conduct comparative analyses of human and animal sequences to better understand the zoonotic nature of this emerging virus and to address the objectives listed here on the slide relevant to understanding the transmission dynamics in animal populations and between human and animal populations, risks associated with host shift events and the emergence of new viral strains, research and science needs to address the zoonotic aspects of the pandemic, and other topics as the need arises. Next slide, please. I also want to highlight an example of collaborative field work. So CDC experts at the invitation of state departments of health and agriculture led on-farm investigations into people, mink, and other animals with SARS-CoV-2. And in addition to collaborating with local and state public health and animal health, as well as wildlife officials, CDC collaborated with USDA APHIS, including the National Veterinary Services Laboratories, who did confirmatory diagnostics for some of these investigations, and also Wildlife Services, who looked at some of the risks of free-ranging wildlife around these farms. And through this One Health collaboration, we were able to learn a great deal about the transmission dynamics between people and animals, both domestic and wild, as well as other at-risk animals on the farm. So again, we're stronger together. Next slide. Through One Health collaborations, we were able to develop joint guidance and recommendations in real time based on what we were learning out in the field with the goal of keeping people and animals safe and healthy. And on the next slide, here are some examples of resources specifically for farmed mink that were collaboratively developed by OFIC members, the production animal subgroup, and state partners as well. So things like how to keep SARS-CoV-2 off the farm, response and containment guidance if this virus gets on a farm. And we even have a handout co-branded with CDC and USDA that was shared with the fur industry, including during several webinars that were conducted on addressing SARS-CoV-2 on mink farms. Next slide. Lastly, we recognized it was extremely important to keep all of our guidance and resources coordinated in one place, including CDC's guidance from the OFIC as well as OFIC partners and our other key partners. So we provided a landing site shown here for easy access as a one-stop shop for partners in the public to find the evidence-based information needed to protect public health and animal health and welfare. And you can find the guidance examples I highlighted in today's presentation at this site. Next slide. So in conclusion, we're stronger together as highlighted by the examples of One Health coordination across federal, state, and other partners during the COVID-19 pandemic. And on the next slide, I'd like to acknowledge our wonderful One Health partners across the US who made our federal coordination to the COVID-19 response a success. And I also want to give a special thanks to Dr. Ann Carpenter, who is our ringleader in coordinating all of our calls and meetings and activities throughout the pandemic. I would like to invite you all to stay connected with CDC's One Health office through the resources shown here. And next slide, thank you very much. Back over to you, Dr. Carpenter.
Thank you, Captain Burton-Baravesh. Next slide, please. Our final presentation, CDC suspension of dogs entering the US from countries at high risk for rabies, is by Dr. Kara E. Williams. Please begin when you're ready.
Hi, thank you. I'm Dr. Williams. I am a veterinary medical officer on the zoonoses team of CDC's Division of Global Migration and Quarantine. I'm one of the managers of the CDC dog import permit, and I'm really happy to be here with you all. Today, I'll be discussing CDC suspension of dogs entering the United States from countries at high risk for rabies. Next. As of July 14th, 2021, CDC implemented a temporary suspension of dog importations from countries at high risk for rabies. No dogs arriving from rabies high-risk countries will be allowed entry into the United States. There are some exceptions that you can see at the bottom of the slide for dogs that have been issued a valid CDC dog import permit before travel. The suspension also includes dogs that have visited a high-risk country in the past 6 months, even if they are arriving from a country not at high risk. CDC will review the suspension periodically to determine when it's safe to lift the suspension. Next. CDC is taking this action to protect the public's health against the reintroduction of canine rabies virus variants and to ensure the health and safety of dogs imported into the United States. Rabies, one of the deadliest zoonotic diseases, accounts for an estimated 59,000 human deaths globally each year, and canine rabies virus variants are responsible for 99% of these human deaths from rabies. Canine rabies was eliminated from the United States in 2007, but it's still uncontrolled in over 100 countries around the world. Since 2015, there have been 4 rabid dogs imported into the United States from high-risk countries. The most recent importation occurred on June 10th of this year, when the 6-month-old puppy pictured here arrived from Azerbaijan with a large group of rescue animals. The rescue animals were quickly distributed throughout the United States before this dog, Alfie, developed symptoms of rabies 3 days after arrival and died from the disease. The multi-state investigation is still ongoing, but 19 people have had to receive post-exposure prophylaxis, and all the rescue animals have been required to be revaccinated and are under quarantines ranging from 45 days to 6 months, depending on state laws. Canada imported a rabid dog from Iran in July as well. This is an international concern, and each rabid dog importation risks the lives of people and animals, and can cost more than $500,000 to contain. The suspension will protect the public's health against the reintroduction of canine rabies from high-risk countries. Next. If you could just tap once. Yeah, that's good. In 2020 and in the first half of 2021, CDC identified a large increase in the number of inadequately vaccinated dogs that were denied entry into the United States from high-risk countries compared with the previous 2 years. These dogs were not protected against rabies, and they present a public health threat. Airlines are required to return dogs denied entry to the country they arrived from on the next available flight. Unfortunately, some airlines have housed dogs in cargo warehouses for prolonged periods before returning them, leading to illness and even death of dogs in some cases. This suspension will protect the health and safety of imported dogs by preventing importations of inadequately vaccinated dogs and by ensuring that imported dogs are housed in a safe manner if they need to be detained for any reason. Next. Dogs arriving from the countries highlighted in blue on this map and dogs that have visited these countries in the past 6 months cannot enter the United States unless they arrive with a CDC dog import permit issued before arrival. The countries highlighted here are mostly in South America, Africa, East Asia, the Middle East, and Eastern Europe. Travelers with dogs arriving from all the other countries on this map that are considered not to be at high risk from rabies, these travelers must provide a verbal or written confirmation that the dogs have not visited a high-risk country in the past 6 months. You can find the list of countries classified by CDC as high risk for rabies on the link on this slide. Next. There are some exceptions to the suspension for dogs that have been issued a CDC dog import permit. These permits are granted on an extremely limited case-by-case basis. Permits will not be issued at the ports of entry, so travelers must apply online for a CDC dog import permit before travel. We recommend applying at least 30 business days, which is 6 weeks, before planned travel to the United States. Next. There are a limited number of categories of types of people who are eligible to apply for a permit. In order to bring your own personal pet, you must be a US or foreign government employee with official orders to move to the United States for government work. For example, with permanent change of station or PCS orders, temporary duty orders, rest and relaxation orders, or a letter from the consulate or foreign government indicating that you're required to move to the United States to do official government work. US citizens and US citizens and citizens of foreign countries who have obtained lawful US residencies, for example, visas, are also eligible to apply for a permit to bring their dog with them if they are permanently relocating to the United States, such as for employment or education. CDC has also made an exemption for return travelers. So these are US citizens or lawful US residents who left the United States with their dog before July 14th for temporary travel, such as vacation or to visit friends and family. In order to be eligible, these return travelers need to return back to the United States with their dog during the transition period, which is the first 3 months of the suspension. So they have to come back before October 14th. Also, to be eligible, their dog must have been previously vaccinated in the United States. So they have to provide a valid and current US-based rabies vaccination certificate. And then lastly, owners of a service dog who is trained to provide service for a person with a disability as defined in the regulations are also eligible to apply for a permit to bring their dog. Next. For dogs that aren't owned as personal pets, an individual or a company may be eligible to apply for a permit for those dogs if the dogs are intended for the purposes of science, education, exhibition, or law enforcement as described in our regulations. Next. CDC dog import permits will not be issued to import dogs for rescue, resale, or transfer of ownership. Additionally, permits will not be issued for temporary travel to and from high-risk countries with personal pet dogs for vacation or to visit friends and family, unless you happen to fall into that category of return travelers in the first 3 months of the suspension, as mentioned on the previous slide. So if you want to travel now or anytime into the future from the United States and go to a high-risk country with your dog will not be eligible to return with a CDC dog permit. Next. For dogs to be eligible for a permit, they must meet 4 requirements. They need to be at least 6 months old, be microchipped, have a valid rabies vaccination certificate. And if they were vaccinated outside of the United States, we are requiring a rabies serologic titer, indicating titer values of 0.5 international units per milliliter or greater. Next. Importers may be granted permits for a maximum of 3 personal pet dogs, but only for 1 trip during the entire temporary suspension. Dogs with a CDC import permit must enter the United States through a port of entry that has a live animal holding facility approved by Customs and Border Protection. And again, this is to help ensure that if dogs entering the United States need to be detained for any reason, they will be cared for in an adequate facility. The current approved ports are JFK International Airport in New York City, the International Airport in Atlanta, Georgia, and LAX in Los Angeles, California. During this transition period, the first 3 months of the suspension, we are also allowing dogs with permits to enter through 18 international airports that have CDC quarantine stations. So before October 14th, you may see dogs coming in through airports like O'Hare International Airport in Chicago or Houston or any of the other international airports that have CDC quarantine stations. And that's just until October 14th. Application submission does not guarantee approval, and denied permit applications cannot be appealed. Next. Dogs not meeting CDC's entry requirements will be denied entry and returned to the country that they just came from at the importer's expense. If the dog is arriving from a high-risk country and does not have a valid CDC dog import permit, or if the dog arrives with a permit but arrives at a non-approved port of entry, or if the dog or traveler doesn't match the description listed in the permit, then the dog will be denied entry and returned at the importer's expense. Next. So in summary, on July 14th, CDC temporarily suspended dogs entering from rabies high-risk countries unless granted a CDC dog import permit. These permits will be granted on an extremely limited case-by-case basis, and dogs without a permit will be denied entry and returned to the country of departure at the owner's expense. No permits will be given upon arrival, and no appeal will be given for denied permit applications. Next. On this slide, if you want to take a screenshot, we've provided the links to all of the CDC websites that explain the suspension and the list of high-risk countries and how to apply for a permit. Next. And if you have any further questions, I'll try to answer them at this presentation, or you can contact my team, the Zoonosis team, at CDC Animal Imports at cdc.gov. Thank you.
Thanks to all of today's speakers for their informative presentations. Next slide, please. We have time for a few questions. Please use the Q&A feature in Zoom to send your questions and include the presenter's name and topic. Our first question is for Dr. Nelson. How many days or hours can elapse between the exposure and administration of post-exposure prophylaxis?
Thanks. Yeah, that's a good question. So in the guidelines, we don't specify a period of time by which prophylaxis needs to be started. But basically, patients exposed to Yersinia pestis by inhalation can become ill very quickly within 24 to 48 hours. So time is of the essence. Within 24 hours of exposure is ideal for pneumonic plague, but it really depends on the nature of exposure. It's possible that patients could still benefit if they had kind of a lower inoculation or a lower risk exposure and have a little more time before becoming ill. So prophylaxis has been provided 3 or more days after exposure out of an abundance of caution. So really it's kind of taken on a case-by-case basis. We are available for consultation when these situations come up, and we're happy to provide guidance and information. Also working with state and local health departments, feel free to contact them or contact CDC info to get in touch with us if there are specific questions for cases. But yeah, that's a good question. Bottom line is time is of the essence, but we can assess as needed.
Dr. Nelson, our next question is for Dr. Williams. Can military working dogs in high-risk countries for rabies return to the U.S.?
Hi, thank you for that question. Yes, we are working with the Department of Defense as well as Department of State for all government-owned animals, working dogs, including military dogs. And we have set up a system in place for them to be able to apply for permits in advance with expedited priority so that they can continue to do the good work that they need to do. And if you need contact information for those working dogs to be able to connect with our Department of Defense point person, they can email us at cdcanimalimports@cdc.gov and we'll make the connection. Thank you.
Thank you, Dr. Williams. We have another question for you.
Sure.
Any idea of how long the importation of dogs from high-risk rabies countries will continue?
So the suspension is intended to be temporary, and we are using this time to develop our regulations and reassess our current regulations to see if we need to update them in order to make dog importations safer and reduce the risk of importing rabies from high-risk countries. And we don't know for sure exactly how long that will take, but we're expecting at least a year for us to continue working through updating our current regulations to replace the suspension. Thank you.
Thank you, Dr. Williams. We have one more question for you.
Sure.
We've received inquiries on military working dogs who are going to high-risk areas and will be returning to the U.S. in an unspecified time frame. Do they still need to apply for an import permit? Also, we have heard that tighter testing is required in order to re-enter the U.S. Is that correct?
Thank you. So the military working dogs do need to get a permit. And again, they should contact us at CDC Animal Imports at cdc.gov so that we can connect them with their Department of Defense liaison who is coordinating applying for all of those permits for military working dogs. And permits are only, serology testing, the titer testing is only required for dogs that were vaccinated against rabies outside of the US. So if they have a rabies vaccine certificate that was issued in the United States, or by, let's say for the military dogs, if the vaccines were given by a US military veterinarian in a foreign country, but using USDA licensed vaccines, then they don't actually require a titer because they have the US licensed vaccine. But for all other dogs that have been vaccinated outside of the United States, we do require a titer. Thanks.
Thank you, Dr. Williams. Our next question is for Dr. Nelson. Do the fluoroquinolones recommended for treatment of plague also cover the other rat-borne infectious diseases like murine typhus that may initially be clinically confused with Yersinia pestis infection?
Thanks for that question. So fluoroquinolones, in particular ciprofloxacin, has been used for treatment of murine typhus, but not regularly, and there's not a lot of good data on that. Doxycycline is really the preferred treatment for that. So, and doxycycline, as you saw in the guidelines, is a recommended treatment for plague, whether it's first line or alternative, depends on the form of plague. So if there's concern for multiple infections, there's always the option to double cover while you're waiting for diagnostic test results. And we always recommend if you suspect plague, and I'm glad this question came up because it brings this up. If you suspect plague, we really recommend just going ahead with treatment, drawing samples and then starting treatment because it's really important to get it on board. And then you can wait for the diagnostic test results. And if they end up negative, you can stop the treatment at that point, but you do not need to, and you should not wait for results of the diagnostic testing to start that treatment for an ill patient who has risk factors and compatible symptoms and signs of illness. Thank you.
Thank you, Dr. Nelson. We next have a question for Dr. Barton-Baravash. What is the process to become a One Health partner?
Sure. So I would say don't wait for an invitation. Pick what your One Health issue or issues are. Maybe it's a specific zoonotic disease like rabies. Maybe it's antimicrobial resistance. Maybe it's dealing with natural disasters and protecting human and animal health and animal welfare. Or maybe it's the opioid crisis. And look at what partners are working in that space and request to set up meetings to discuss your concerns and your work and potential areas for collaboration. And also always check to see who else they suggest you might talk to. And that really goes a long way in building One Health connections and forming One Health partnerships. Thanks for that question.
Thanks, Dr. Barton-Baravash. We have one more question for Dr. Williams. In the situation of non-government animals attempting to leave Afghanistan, is this moratorium being reconsidered for the affected pet dogs there to allow them to arrive in the U.S.?
Yes, dogs that are currently in Afghanistan or that have recently left Afghanistan, the owners of those personal pet dogs are eligible to apply for a permit, and we can expedite the issuance of that permit so that they can come into the United States. But they do need to meet all of the requirements listed previously in this slide. Thank you.
Thank you, Dr. Williams. We have another question for Dr. Nelson. The prophylaxis guidelines presume a recognized point exposure. Are there proactive prophylaxis recommendations for persons enduring elevated risk, for example, biologists working with wild rodents?
Thanks, Dr. Fritz, for that question. So we do have pre-exposure prophylaxis recommendations in the guidelines. They're reserved for very specific circumstances. For example, if a healthcare worker is seeing patients during an outbreak and there's a lack of PPE or patient overcrowding, lack of ventilation that really would increase their risk of acquiring plague, and they are not able to use those non-pharmaceutical measures. So in those cases, pre-exposure prophylaxis can be considered, and we are certainly available to talk through that. For other situations, for example, when you brought up a field biologist, we haven't typically recommended pre-exposure prophylaxis for those situations. We usually recommend kind of education of folks and protecting themselves by using repellent and other means and being on the lookout for symptoms and being aware of the symptoms of plague. But again, we are available for consultation, and if there are unique situations in which it's felt that could be helpful, then certainly that might be a consideration.
Thank you, Dr. Nelson, and thank you to our other presenters for responding to these questions. If you have other questions for today's presenters, we've included their email addresses on this slide, on the ZOHU Call webpage for today's webinar, and in today's email newsletter. A video of today's webinar will be posted within 30 days. Next slide. Please join us for the next ZOHU Call on October 6th. Thank you for your participation. This ends today's webinar.